Aphakia is not a contraindication to DMEK. These operations are surprisingly possible in eyes that have no lenses, not only because a lens is not necessary to perform a DMEK procedure, but also because it has become so simple and easy to implant an IOL at the time of an intended DMEK procedure. There are a variety of different IOLs and maneuvers and methods that can be utilized. My own personal favorite these days is Yamane IOL fixation. And here I want to show you a video of a recent case that we performed involving IOL implantation with combined with DMEK. So this is an eye that has previously been vitrectomized and is aphakic with a corneal scar from a childhood injury. In the aftermath of that injury, the eye was left aphakic and the cornea decompensated somewhere along the way, and this patient was treated with a DSAEK. And oh, by the way, the patient developed a glaucoma at some point, and so this eye has a tube shunt as well. So to recap, we have a traumatized eye with a corneal scar, a failed DSAEK, a tube shunt that's aphakic. And the patient presented to us because this DSAEK that had been previously placed is now failed. And now he needs something principally for pain relief because he has bullous keratopathy. But we thought, well, perhaps it would be possible to do something that would improve the vision a bit as well. So the planned procedure here is we're going to implant a lens with the Yamane technique. We're going to trim the tube shunt, and we're going to replace his failed DSAEK with a DMEK. Now, because of the complexity of all of this procedure that we're stacking together, we've decided to perform the operation under general anesthesia. And that is my own personal psychological choice here. It just makes me feel a little bit more calm and comfortable knowing that the patient is going to be completely anesthetized for the duration of the operation. But probably you could do this operation quite conveniently under topical or retrobulbar anesthesia. Now, I'm placing some pars plana ports here, and the reason I'm doing that is even though this eye has been previously vitrectomized, I want to make absolutely sure that there is no lingering vitreous anywhere, so I will do a little bit of a just sort of a cautionary vitrectomy myself to make sure that there's nothing there that we would get into trouble with. And also it's nice to have some pars plana infusion. So here I am placing a second port that I'll use for infusion purposes. Now, just like the retina doctors do when they put a pars plana infusion in, they always confirm that the infusion is not subretinal. So that's the first thing I'll do is after I place these ports, I use the light pipe and I look around and make sure that I can see the end of the infusion port before I proceed. So once that's done, once I've confirmed that the port is not subretinal, then I will do a little bit of a cautionary exploratory probing pars plana vitrectomy to make sure I don't see any movement to verify that there's not any vitreous left over that we need to tangle with. So once that's done, I will make my incisions here. So I've made my paracentesis incisions, and now I'm making a 3mm temporal incision. And I'm scoring that wound before I begin my travel up into the cornea because I like a nice, thick posterior edge that I can grab when I'm inserting my IOL. And rather than just a normal 3-planar incision, I like to score there because that ensures there's no ripping or tearing of that thin back edge of the wound when you're inserting a big lens. So now I'm removing these air bubbles from the anterior chamber just to clear the deck so I can see what's going on. Now you may notice here superotemporally at the bottom left of the cornea, you'll observe an air bubble trapped at the mid-periphery there where the cannula is interacting now. That's the edge of the tube shunt. It's indistinctly visualized in this video, but that's where our tube is. That's relevant not only because we'll deal with the tube later in the case, but also it influences where I make my needle passages for my Yamane technique. Because he's got this tube in the eye, we have to avoid that tube. This is an Ashvin Agarwal marker that I have marked using gentian violet marking pens, and this allows me to plan where I'm going to make my Yamane passages. Now the nice thing is that the back edge, the posterior limiting point on these purple marks is about 2.5 mm from the limbus. And these prongs are about 2.5 mm from each other. So that is a wonderful, useful little tool because you know that you can put the needle at the posterior edge and pass it from one of these prongs to the other and then dive in, and that's precisely where you want your Yamane needle passages to go. So you don't really have to use calipers to measure. You don't have to make multiple additional marks on the cornea. This little tool provides all of the landmarks you need in order to perform Yamane technique successfully. So here I have the first needle passed into the eye. This is a 30 gauge thin wall TSK needle, and I'm passing it there as now I'm loading the lens into the eye. Now the lens that I like to use nowadays, this is an MA50BM lens from Alcon, and I prefer that over the Zeiss CT Lucia for several reasons. Number one, it's more commonly available. Number two, it's less expensive. And number three, and most importantly, the optic is bigger. This is a 6.5mm optic in contradistinction to the 6mm optic of the CT Lucia, and I like that because it's more forgiving of decentration. So here I am injecting the lens into the eye, and you'll notice that I'm finagling the leading haptic into the bevel of the needle. I'm docking the haptic directly into the needle. And once I have the haptic docked into the needle, this is very controlled, by the way. This is very, very easy. You have wonderful control of the haptic in the needle. Then I push the lens into the eye, and I will just go in through a paracentesis with some coaxial gripping forceps and just sort of tuck that haptic a little bit deeper into the needle. And that makes loading this initial leading haptic so much quicker, so much easier, so much simpler. There's much less fiddling and fooling inside the eye. So now I have the leading haptic externalized. I'll grab it and I will lift it away from the surface of the eye. Now what's important, as everyone knows, when you're doing this Yamane, you don't want to be cauterizing something wet. Otherwise you get sort of this shriveling, shrinking instead of this firm bulb forming. So you want to lift that up out of the pooling on the surface of the eye and cauterize it. You don't need a big bulb. It's not easy for that to slip back inside the eye. So a small bulb is sufficient, and then I tuck it most of the way back into the sclera to give myself maximal play to work with. Now it's time to dock the trailing haptic. And I do this in the way that I learned from Dr. Dick McCool. He's got a great video on his website that shows that it's so much easier to dock the trailing haptic of the Yamane IOL if you'll do it outside of the eye. So I'm passing this needle just from my other Ashvin Agarwal marker. I'm diving into the eye, and now I'm going to externalize that needle from the eye. I'm going to use a cyclodialysis spatula through the main wound. I'm going to ramp up on the wound, over the lip of the wound, and push the iris down. And then I'm going to pull the needle out of the eye. And the reason I'm doing this is because this way you can dock the haptic and the needle outside of the eye. And that is so much easier than trying to fiddle with these things inside the eye. So here now I've got the needle outside of the eye, I've got the haptic outside of the eye, and it's so easy just to put the haptic inside of the needle. Okay, so there we go. We're just going to put the haptic inside of the needle and then just pull it out. Okay, so now we have both haptics externalized, and we're ready to proceed. So the IOL is centered, it's stable, the haptics are pulled out, and we can proceed with the next component of the operation. In this particular case, what I'm going to do now is I'm going to strip the DSAEK graft off the back of the cornea. I like doing that with an air fill. So I'm going to use an AC maintainer. I'm going to put air in the anterior chamber, and I'm going to use this inverted Sinskey hook to start peeling this DSAEK graft off the back of the cornea. And it's thick and fibrotic, and it's tough. And one thing you'll see as we proceed in this case is there is a retrocorneal membrane peripherally that I'll need to engage and strip. But I like doing this after the lens is inside the eye, and that gives me the confidence that I'm not going to inadvertently drop something into the back of the eye. So there we've got the DSAEK graft pulled from the eye, and these are max grip forceps, coaxial gripping forceps that I'm using, and I'm going to use them to engage and strip the remnants here from the periphery of the cornea. What you'll find basically is that there is a thick retrocorneal membrane, and it comes off in these big chunks. And I think it is important, if you're putting one of these delicate, diaphanous, thin DMEK grafts on the back of the cornea, to get all this crap off the back of the cornea, which would interfere with attachment, not to mention just cloud your otherwise pristine cornea. So this is tough material. It's like shoe leather. So you need to be able to grip it with some strong forceps inside the eye and peel it off the back of the cornea. So now that that's done, what I'm going to do is I'm going to trim the tube shunt. The way that this is accomplished is by using coaxial forceps 180 degrees away from coaxial scissors. Now, I prefer to use 23 gauge curved retina scissors. These are 25 gauge because we didn't have any 23 gauge, but you stretch the tube, which makes it thin and skinny. You pull on the tube and you cut with these coaxial forceps, or coaxial scissors rather. And the stretch ensures that the tube is skinnier and easier to cut, and also it allows you to cut more of it. So now I've amputated the tube and I'm just passing it out through the main wound. Okay, there we go. So now the tube is cut. And you'll notice here that I have still a big iris. So the lens is in place, it's centered, the tube is cut. And the question is now, well, what to do with the iris? Should you just leave the iris like this? Is that sufficient, or do we need to address the iris? It's a little bit on the large side. So the option we have is suturing the iris. Now, whether or not that is a good idea sort of first presupposes that it's possible. In these eyes that have long-standing trauma, the iris and the residual anterior capsule are often fused, and the iris is fibrotic. So I'm using here a cyclodialysis spatula to see if I can get in between the iris and the fused fibrotic anterior capsule. And here I am just sort of wiggling it around, trying to find a plane maybe in between the iris, because if you can't separate the two, there's no way you can suture the iris. So I'm looking here to see if I can establish a plane. And the plan is just to delicately tease around and see if I can find some separation between the two tissues. Okay. So I see a little bit of bleeding. Okay, I'm still trying to delineate what's going on. I see some scar tissue. And what I'm going to do now is I'm going to remove that scar tissue and remove this bubble so I can see. I'm going to use some coaxial forceps here. And I'm going to try to see if I can get some iris mobile enough to suture. Okay, so that's the plan here. So I've got these coaxial forceps, and I'm just going to see if I can get any play in the iris. So I'm pulling here. Can I get the iris to move? And you'll notice as I pull here with these forceps, it just breaks off. So the iris is brittle. It's dead. And there's just not going to be any suturing this here at all, okay? So rather than try vainly to sew up the iris, I decide that really the better part of valor here is the discretion to know what not to do. So I'm leaving the iris alone. So I'm removing these ports now, okay, because we don't need access to the posterior segment anymore. And I've decided not to sew up the iris. So now it's time to deepen the chamber and get ready to implant the DMEK graft, okay? So I'm hydrating our wounds here, and I'm checking to see, is the eye firm? And you'll notice as I'm tapping around, I've hydrated the wounds, the eye is still soft, okay? And this is a no-go. You can't inject a DMEK graft into a hypotenuse unicameral eye, basically, because you risk losing the graft into the posterior segment. Not to mention your manipulations are just ineffectual. If you can't have a deep, firm chamber, you don't have control over what's going on in the anterior segment. So I'm still deepening the chamber. I'm trying to make it firm. I'm going to hydrate the wounds. I'm pressing to see, is it firm? And the answer is still no. And the reason it's still no, I learn, is because I'm leaking from one of these pars plana trocars here. So I'm going to take the conj down. That's where I had my initial port, and you'll notice that it's leaking. So you've got to sew it up. You cannot leave this eye hypotenuse if you're going to put a DMEK graft in. So I use some 8-0 and I'm going to pass that through that port incision, and I'm going to sew it up, okay? And once that's sewn up, now I will repair the conj sort of in a similar way, and we have a firm eye again. So now it's time to insert the DMEK graft. This is a large graft. This is a 10 millimeter graft, and I prefer to use large grafts when I'm dealing in hyper deep chambers because you get better apposition between the periphery of the cornea and the tissue. Now, the first step always is to remove the bubbles that were injected inadvertently with the graft because they compete with you for control over the tissue. They cloud what's going on in the eye, so I remove the bubbles. Now, here's a pearl. When you're removing bubbles from the eye, you always want to use the cannula with BSS and never remove air from the eye using an air syringe. The reason is if you remove air from the eye with a syringe with air, you'll get foam and froth inside the cannula and the syringe. And then when you go back to inject air in the future, you'll inject a profusion of fish egg bubbles. And if you're injecting air in the eye and you get all these bubbles all over the place and you can't figure out why, it's because you're aspirating foam up into that syringe. So when you're removing air from the eye, you always use the BSS cannula and syringe and never your separate air cannula and syringe. So here I am removing air bubbles from the eye. So there the graft is in the eye, and the eye is soft, okay? I've just injected a graft. It's not hypotenuse, but it's soft. So the graft is currently scrolled up in the eye, and I want to get the graft to unfold a little bit. One very effective maneuver is to inject BSS down the lumen through the barrel of this curled graft. And you'll notice it's perfectly positioned immediately adjacent from the main wound. Now, I like to use the main wound. I'm not afraid of flushing the graft out from the wound because as long as you keep the pressure in the eye low, you're not pumping up the volume of the anterior chamber and then burping the main wound, you're not going to eject the graft. So I'm not afraid of the main wound. I like to use it. So I'm going to inject and direct fluid intentionally through the barrel of the graft from the main wound. So here we are. That's what I'm doing. And of course, I've still got air. So I remove the air, and now it looks like the graft is open a little bit. Now, I will tell you I'm about to make a mistake. I'm deceived here. I think, looking at the graft there, that it looks right side up to me. So here I am sort of testing with the cannula, and I'm not really getting a good Motsuro sign. I can't really get the edge of the cannula to engage the edge of the graft, but my own perception is the graft is right side up, so I'm putting an air bubble on top of the graft. That's my preferred technique for unfolding grafts in these hyper deep chambers, to put a bubble on top and then grab the graft with coaxial forceps and move the graft against the bubble. So I think the graft is right side up. It's not, it's upside down, but this is what I'm trying to do. So I've got a bubble on top of the graft. I think the graft is right side up, and my plan is to use these coaxial forceps, grab the graft, and drag it over to bubble bump it against that floating bubble in the eye. So I'm trying to use these coaxial forceps to engage the graft, and you'll notice I'm not really getting it. I can't really grab, and I'm not really sure why. Why won't that work? Why can't I engage? And of course, the reason it won't engage is because I'm on top of the graft, and the graft is curling down. It's curling underneath. So that's the reason why I can't grab it. If you go back and watch the video, you'll notice when I put that air bubble in, as the air bubble elevated, it did not interact with the edge of the tissue. And that's actually how you could tell definitively that the graft was upside down when I put the bubble in. But I have not figured that out yet during this case, okay? And I want to show you this in its full unedited forms. That's why I'm not fast forwarding here, okay? So I'm going through the main wound, the paracentesis didn't work, and I still am not smart enough to figure this out. So I'm looking here, I'm moving the bubble over, what's going on? Why can't I grab that graft edge? So now I think, well, maybe if I make the bubble a little bit smaller, perhaps that would help, okay? So this is, again, the BSS cannula. I'm going to shrink the size of the bubble, and now I'm going to go in again with these coaxial forceps and see, okay, well, the bubble is really small now. I should be able to grab it, and still no. And then I think it dawns on me, okay, well, that's the problem. The graft is upside down. So I remove the air bubble, and now it's time to flush the graft. So I depress the wound, I flush the graft here. Okay, this is BSS, and I'm flipping it, all right, and one tap on the cornea. And you can see sometimes actually it's better to be lucky than good. The graft flips over and basically unfolds itself. And what I want to show you here is actually, I mean, a lot of people perhaps are intimidated to do a case like this, but you see really actually once you just have the graft right side up, it wants to open, it wants to unfold, and having the large graft here really helps you. I'm putting an air bubble here underneath the graft, and now you'll see it's lifted up to the back of the cornea, and I'll put a few taps here on the surface of the eye, and what you'll notice is the graft is basically completely unfolded with very little manipulations. As long as you have the graft right side up with a large graft, it wants to open even in these complicated eyes, okay? So there are two little edges here left to be unfolded. The inferior edge, I'm just going to put a few Dirazomer taps on the surface of the cornea here, okay? And you'll notice that that edge comes right out, okay? Now, once this edge is opened up, I still have to contend with this superior fold. And this is a weird looking fold, you'll notice. There's sort of a kink in the graft, and that's because that's where the tube shunt is. The tube shunt is interfering with that edge of the graft being unfolded, okay? So the way that you deal with this is I'm just gonna go underneath the graft just with my cannula and just manually lift it up a little bit, okay? So it's quite easy to do that. There's a little remnant there of retrocorneal membrane I'm just peeling off with these coaxial forceps here. I just notice it there in the interface, so I think, okay, well, let's just go ahead and get that out. But that is, the whole trick here is just to manually lift that little edge of the graft up over the tube shunt with the cannula. So here I am, I'm just lifting it up, and there we go. Now it's on top of the tube. And you can see with this large graft, how beautiful that looks in the eye. This is an eye in which you're going to be quite hard-pressed, really, unless you look carefully to tell it's ever had a DMEK before. Now, one thing you'll notice, by the way, is that I did not make an inferior iridotomy during this case at all. And the reason is this eye is post-vitrectomy. It's basically unicameral. And it also has a tube shunt. And so it really isn't necessary to have an inferior iridotomy during this operation. You can dispense with that component of the procedure. So what I'm doing now is I'm just going to put air to fill the anterior chamber to lift the graft up from behind. I'm finagling into the anterior chamber here just with my air cannula. I'm just wiggling underneath the edge of that transplant. It's a large graft, so you have to be a little careful when you're doing it, but it's not difficult to do. And once you have the bubble lifting up the graft, well, the operation is basically over at this point. So the reason I show this video is not because there are any acrobatic surgical maneuvers. I think basically all of the procedures in this surgery are very simple, they're very straightforward. There's no real surgical technique that is any way unique to me or special to me. It is to show you basically how you can combine little easy steps in an operation together that would make an otherwise seemingly challenging surgery easy. So just because the eye has a tube shunt, it doesn't mean they can't have a DMEK. Just because they have a widely dilated pupil doesn't mean they can't have a DMEK. Just because they're aphakic or have a DSAEK or have a childhood trauma or a scar in the cornea doesn't mean they can't have a DMEK. And you can do all of these operations together, and it doesn't add or stack complexity. They're all just one little simple step after another. So I invite you to start doing DMEK in these cases if you aren't already. I think you'll be thrilled with the results and really quite proud of yourself and glad for the benefit your patients receive.